just to introduce it again, this is a collaborative effort between the Journal of Neuro-Oncology and Lenox Hill Neurosurgery, where we like to sit down with the authors of recently published articles in the Journal of Neuro-Oncology. And we discuss really the reasons, the results, and the rationale for the studies and how they relate to brain and spinal cord oncology. So today we have a super special guest, Dr. Quinones from the Mayo Clinic and his team. I'm going to let you introduce your team because I don't know them as well as I know you. And then we'll get going. We're going to talk about your guys' recent paper discussing potential differences between monolingual, bilingual patients in approaches and outcomes after awake brain surgery.
Beautiful. Well, I'd just like to introduce Dr. Karim Rifai, who is an outstanding postdoctoral fellow, trained in Egypt as a medical student, finished his medical school, came and spent time with us, first at Johns Hopkins before I came here to the Mayo Clinic, and now the Mayo Clinic. He's been really, truly revolutionizing the way that we think about cortical mapping and recording, and especially this issue of bilingual patients. Of course, he himself being bilingual, myself, thinking about a lot of the patients that we see around the world. And he's been an innovator and a thinker, and you'll see some of the devices that he has invented with us are the things that we're using to monitor patients. And then we have a tremendous colleague, Dave Satsuvis, who is a neuropsychologist by training, but really, truly is an amazing innovator. He is, I like to think of him as someone who pushes us in the boundaries of what we can do in surgery. He does amazing work. He's also an innovator. He's created software that we use in some of this mapping in the operating room with bilingual patients. And he'll tell you a little bit about the work and how we are monitoring these patients in the operating room. And then myself, I follow the lead of these leaders. I like people say that I'm the chair of the department, but the reality is I follow the lead of these young people who are teaching us the way of the future. So yes, as Randy, as said, as Dr. D'Amico said, we'll talk to you a little bit about our work. We prepare a few slides only. The idea is to collaborate and to talk about this and what we're learning from each other, because I know that you guys do similar work in your own operating room. So hopefully we can bounce some ideas back and forth. So here we are, ready to rock and roll.
Absolutely. So who's going to share their screen? Is it Karim? Is it you?
Dr. Karim has a few slides that we review, both David and I, and then we'll go and you stop us at any time. I think we only have 4 or 5 slides that we prepare.
No problem. While you pull it up, I want to introduce Nitesh Patel. He's filling in for Gautam Mehta today. He's a resident at Rutgers, one of the chiefs there, and he's going to be helping us out on kind of the back lines of Tumor Talk, but also, chiming in when we can have him. So welcome, Nitesh.
Thanks, guys. Thank you so much.
Can you guys see my screen?
Yes.
All right. Well, thank you for having me, and thank you, Dr. D'Amico and Dr. Sheehan, and thank you, Dr. Q, for the introduction. So this is a paper that we recently had the pleasure publishing in JNO. So we don't have any financial disclosure, unfortunately, but what we want to disclose is Dr. Q, Dr. Tatum, who is epileptology, and myself, we filed an intellectual property for some of the devices that we use in the OR for brain mapping. So why we did this project? So bilingual patients, they have a lot of studies show that the bilingual patient recover faster after a stroke, and also they have a little bit of advantage in multitasking. And so we look at that, and nobody else look at that from the brain tumor perspective. So we wanted to hypothesize that is there any intraoperative issues or intraoperative considerations that we can take for this population. So we asked 3 questions. The first is there any difference between the extent of resection? And second, is they recover faster, or they recover less, or nothing at the same? Or the last thing is there any risk for mapping? Because is there any risk for seizures? Or is we applying electrical current higher, lower, or the same? So we didn't know the answer to this question. So we went back to...
I pause a little bit right here, Karim, just to formulate the question. So I think that as we understanding more and more the cortical and the subcortical organization of the brain, I think it's important for us to think that we used to think of several areas of language, Broca's area, Wernicke's area, but now we're beginning to understand through all these modern images and imaging of the brain, and many papers like JNO has published, there's a connectome of pathways that are allowing us to maybe understand language better. And this is really where David subsidies has been a leader in pushing us and to think about the paradigms that we use to test patients when we are in the operating room. So yes, those are the questions. And this is really the experience that we have acquired here as I thought more and more from my years at Hopkins when I was doing it slightly different. So hopefully this study will be the initial study that would allow us to begin to think about some of these questions that Karim just formulated right here.
All right. So to do this, we look at retrospectively at 14 bilingual patients and 42 monolingual patients that had left-sided tumor and had left-sided awake craniotomy. So, and also we evaluate the education level. Most of the patients, they have education level equivalent to graduate degrees or undergraduate degrees. And the age of language acquired, also like that's something we ask the patient about. So also we have the number of intraoperative stimulation, how many times Dr. Q stimulate the during using the Osman stimulator, or how many the current, how many is 2 milliamps, 6 milliamps, how many difference between those. So the results came back. Some of them are exciting, some of them are we expecting them. So preoperatively, there is no.
I add right here, some were exciting, some were very confusing.
Yeah.
I hope that people understand this is just, hopefully this will motivate more people to look at their own series as they're doing this. So you'll see.
So on the age and sex, we didn't see any differences. Also, the KPS, it was very similar. So I want you to focus on the preoperative KPS because we're gonna go back to it later. So, and also we measure the volumes of the actual tumor in 3D and we didn't find any difference. The seizure medication has no difference as well. So we look at.
To the best of our knowledge, these patient populations were very well matched. As far as we can tell from this, these are the things that most of us are looking in our own patients. And I'm sure people can look at more, but we thought that these were the ones that we can readily look at and make sure that there were no striking difference that will favor one patient population over the other.
Yeah, correct. Absolutely, yes.
So I would say certainly similar tumor volumes, as shown here, pretty sizable ones at that.
Correct.
Yeah.
That's right, Jason. And that was important. You'll see right now, because that's going to be some of the results that we're going to show. And I welcome your feedback as well, based on your own experience with these patients.
And these are all gliomas primarily, right?
Yes, Randy. You'll see the pathologies, the grades, but yeah, they're all gliomas. That was the thing, because they're thought to be more intrinsic into the brain. We rule out all the meds. We took out all the other stuff. We try to put a population that we can relate to in regards to the way cells migrate and invade parts of the brain.
Absolutely.
So we look at intraoperative analysis of this patient population. We look at the seizure. We find that none of the bilingual had seizure and 3 of the monolingual had seizure, but still there is no significance between them. The number of stimulation was quite similar, but when you look at the milliamps, or the range of current, was much higher in the bilingual in comparison to monolingual. That means they can tolerate much higher current. And despite
this is important right here. This is what we do, is we start stimulating, we keep going up and up and up and up, and we record. You'll see a video that Karim is going to show you, until the point that we start getting after discharges. That means that we're about to give the patient a seizure, all right? That's based on electrocorticography that we do with our neurologist. And of course, with David there looking at the neuropsychology and making sure that even if we're giving them electrical seizures by our grid that we use, the patient continues to test well. But we know we're right at the edge of giving the patient a seizure. So this one told us, at least in this patient population, the bilingual patients, we can push them a little bit higher.
So we also look at postoperative analysis. So from seizure perspective, only one from the bilingual had seizure, while monolingual didn't have any seizure. But the KPS was much more significance. So it was 84 in bilingual and 77 in monolingual. And the delta KPS, which is like the change in KPS, like the difference between the preoperative KPS and postoperative KPS, shows that bilingual has less drop in KPS in comparison to the monolingual. And if you go back to the preoperative KPS, it was 88 and 86, and postoperative, it's 84 and 77. So one could argue is like, yeah, because the extent of resection, as we're gonna go through more, they have like a little bit much higher KPS, but it's having like the similar, more or less KPS preoperatively.
Well, and one can argue right here, and I posed the provocative question of the hypothesis and the rationale of doing this study when we start thinking about it. As Karim said, we were working under the sort of the guidance of R.G. Killis at Hopkins, who's done a lot of work in bilingual patients with a stroke. And the hypothesis that they have had in the stroke field is that those patients that are bilingual, they tend to recover faster and better and have a better quality of life when it comes to language. So one could potentially argue right here that patients that are bilingual, they're maybe a little bit more resilient to some of the networks that one affects in language. However, the counterpart is going to be the extent of resection, which you are going to see that at least in our hands was less that we can achieve in resection when it was bilingual. So Karim is going to show you that.
I may interrupt. Just a quick question. How does you guys talk about age of acquisition of language, which is really fascinating. You know, it's something that I necessarily don't think of right off the bat. How does that affect, you know, how these patients recover and just sort of planning in general?
Beautiful. Karim, why don't you, in our study population, tell Nitesh what we had for the age of acquisition, which is a very relevant question here.
Yeah, so that's a great question, and thank you for this question. So the bilingual patients are divided into, or bilingual population, early bilinguals and late bilinguals. And the cutoff is from 6 to 9 years of age. That's based on literature from like other like functional MRI literature and linguistics literature. And it shows that like the early bilingual has much more concise areas. Like if you have like a one sort of like cortex for the, if you say for the language, but for the bilinguals, the late bilinguals, I'm sorry, it has much more diffuse. So I'm gonna repeat that again. So when they have like the early bilinguals or the early age of acquisition before age of 6, the like population or the like the people tend to have much more concise area of language. But with late bilinguals, they have much more diffuse in language. But in our tradition, the population, most of them has like from 6 to 9 years of age, which is much more challenging to do like surgery on because we have a much more diffuse areas of language.
So let me ask a question, Karim. I think that, let me just clarify. If you acquire the language early, and this is something, that was a study that I had done in 2003 that I published with Mitch Berger, bilingual patients. So the later in life, the more diffuse the language. So for instance, I acquired English when I was between 17 to 19 when I came to the States. So I'm pretty sure if you do a functional MRI, I'm gonna have diffuse areas of language acquisition. If you acquire your language when you are between 0 and 6 years of age, you're going to have your language very concentrated. That's studies that have come out of Europe, because a lot of people are bilingual since very early in age. Our patient population, Karim, how old were they when they acquired the bilingual language?
So they were late bilinguals. They were above 6 years of age.
So we're 6 and above. They were considered later in life. They had already acquired one language. They start talking their first language from 0 to 6. So they're considered late. So by definition, most likely they're going to have the diffuse language. And that's actually something that you saw in the functional MRI that Karim showed at the beginning, where we have several areas that are spread out throughout the brain. That's a very relevant question.
I want to say, I hope we can get a little bit into the functional MRI part, which you talked about a little bit in the discussion. There was almost a teaser to I'm sure what are other analyses that Kareem and others are going to do, but let's let them finish. But fascinating work, and the functional MRI part, I want to hear more about if you can, without compromising future works.
Yes, and we let David comment on that, Jason. That would be great. So David, hang out for that so we can review, finish the analysis and go into that.
Thanks.
So here, as Dr. Q said, like the bilingual patients, they tend to have less extent of resection in comparison to the monolingual. And when you see like here, if the extent of resection, one could argue that the extent of resection that less, so that's why the bilingual has much higher KPS. But we argue that they have like similar KPS, like the monolingual and the bilingual preoperatively, and postoperatively, that's what we observe with them. So we'll move forward. Let's see. Okay. So for the tumors, we have all gliomas. We differentiated them into high grades and low grades. And we also like did glioblastomas, oligodendrogliomas, anaplastic, and astrocytomas. And also we did a subset analysis that I don't show here in the slides, but we actually included in the paper, that we divided them into only high grades, and we didn't see any differences between this subset analysis and actual analysis. So this is very relevant because some would argue that the high grades, they don't survive as much, and they don't tend to have this like diffuse language. And others, they say like the low grades, they might have like some sort of like plasticity, if you say, and that's the makes the language diffuse. But all of these are much more or less a hypothesis, and we don't have a real evidence, like level 1 evidence now. So I will here show the video. Okay. So this is a patient, 32, right-handed patient, Hispanic. He presented with seizures, and he was operated on by Dr. Q back in 2013 for oligodendroglioma. And after that, he came back earlier this year with increased enhancement or increased T2 flare on the tumor bed. So we decided to take the patient to the OR in supine position. As you can see here, the skin incision and elevation of myocutaneous flap. We're gonna use the same craniotomy, but we're gonna extend a little bit posterior to have the portion of the progression. And here we're using the craniotomy, the drill, foot plate. And then after elevation of the bone, we gonna opening of the dura and the dural substitute. So after that, we're gonna proceed right away. We're gonna put the circular device to read to monitor the brain. And Dr. Sapsavitz was in this case as well. He has a patient map them in English and Spanish, like words.
Spanish and English, here we go. Esto es un águila, this is a novel.
And this is a device, and you can see here, we had a prolonged after discharge when we stimulated this area, and we had to stop. And we had to stop and use the cold water irrigation to stop this after the discharge. However, like all of that, Dr. Sapsavitz was using was asking the patient in English and Spanish and mapping them. So after
sorry to interrupt, what's the utility of the circular electrode? Is that a proprietary thing that you guys use?
So we file a patent for it, and the use of it is allow us to have a contact to the brain and stimulate at the same time. Because if you have a couple of straps, you have it on the side, and some of the electrical activity might escape from the other side. So we have it in a circular shape. So you put it on the area that you want to resect and stimulate inside and see where exactly this area coming from. Not only that, but when you resect, you can resect from the middle, and you see if there is any after discharge coming from the tumor bed itself.
Yeah. for those of you who are able to access the article, I hope all of you, it's figure 3, A, B, and C, where that circular grid is shown. And that caught my attention too when I was reviewing the paper.
So I mean, fantastic work. Are you going to finish here?
Most I have like here the limitation and the conclusion.
Oh, perfect.
But if you want me to stop that.
No, go ahead. Go through it.
Okay.
I'm probably going to answer all my questions.
Thank you. So as Dr. Q mentioned in the beginning, this retrospective study is much more like an observational study that we saw and want to tease out the questions about this patient population. Also, there is like selection bias because we only included the patient who had awake craniotomies, and also for the age of acquisition, all of our population have like above 6 years of old, so they are considered as late bilinguals. So we don't really know about the early bilinguals. So, and also we have like a small sample of bilinguals that's affect or might skew our results. So in conclusion, bilingual patient has less extent of resection in comparison to monolingual, and they have small postoperative decline in KPS and lower incidence of intraoperative seizures, but can tolerate higher electrical current intraoperatively. And we just, as I said before, the purpose of this paper is to tease out the questions and the ideas out there to look at this patient population. And
well, congratulations. I think fantastic work, very, very provocative in terms of, not just neurosurgery, but neuroscience, right? The way language is processed. I think that's the absolute importance here. Maybe this is a question for Dr. Sasovitz, but what was your questioning like for bilingual patients? I imagine it varied based on where the tumor location was,
right?
But was this a prolonged experience compared to what you normally do, or did you guys follow your usual protocol?
It takes longer because we're evaluating in 2 languages, but we try to decide what tasks we're using based on the anatomy of the patient. I mean, what the literature shows is that in patients with a second language, there's a large amount of overlap anatomically between the 2 languages. If you go back over the fMRI literature, for example. So it seems like the second language is, mapped onto similar anatomical regions as the first. And with the second language, there's some data showing that there's some recruitment of additional areas above and beyond the primary language. And maybe it's because it's more difficult with the second language or what have you. So, we form hypotheses based on the anatomy. So if a tumor is, let's say, located in certain phonological areas of the brain, we'll test phonology in both languages. If it's more of a semantic or lexical semantic retrieval, we'll test that. So we have a variety of different tasks that allow us to interrogate those different systems. Now, what we don't know, again, is at a fine level of detail, what does that look like in both languages? And we're hoping to collect that data over time.
Absolutely.
David, can you talk a little bit and Q and Karim, feel free to add a little bit about, as I said, there was that teaser in the study limitations talking about the preoperative functional MRIs performed in these cohorts. But can you shed a little bit of light on what you may be seeing that could relate to some of the language findings that you've noted here? And do you routinely do functional language mapping on all your glioma patients? I guess that would be the start question. And then
yes,
any glimmer of insights you might have with the functional MRI mapping
sure.
for these bilingual patients.
So we do. We routinely collect fMRI and DTI in all of our surgical patients, and we can map in multiple different languages using different paradigms. The question of, what have we gained knowledge-wise from the fMRI data and surgically? My experience has been that, we use fMRI to form hypotheses, to generate surgical targets for mapping. So we get these beautiful fMRI maps. We don't alter our surgical approach based on strictly the fMRI. There are no-go areas because of the fMRI, but what we'll do is we'll take those, we'll target those with stimulation and try to confirm and verify those. And what I found is, it's all over the place. We can stimulate areas of large bold activation and not produce any clinical deficits, resect those areas, and patients can do well. we can stimulate areas where we have no bold activation and produce a deficit, and we try to avoid those areas. I think that speaks to fMRI as a method will show us activation that is critical to a function that we wouldn't want to take out, but it'll show us activation that is supportive and potentially could be resected, as well as even, non-essential activation that is doing other type of processes to perform the task. As far as how all this relates to monolingual versus bilingual, I'm not sure. I mean, again, I think my experience is that the monolingual stuff generalizes a little bit in just how we use that fMRI data. Does that answer your question?
It does, and I think that one of the critical parts that I think I'd like to underscore based upon what you've found here is that there's really probably no substitute for your intraoperative mapping, and I think that lots of others have found that, but what your comments related to the complexities of these cases in this work, I think underscores it even more.
And what this study, as well as our experience working with bilingual and monolingual non-English speaking patients, because we have a very busy practice when it comes to international patients and mapping in multiple languages, that there's a huge need for this. There's a gap in sort of the clinical tools needed to effectively evaluate and map these patients. So, our team here is putting a lot of focus on trying to come up with paradigms that are informed conceptually, but allow us to map across multiple languages.
So I got to ask, what do you guys think about the early bilinguals? What do you think the difference would be if you looked at a series of early bilinguals versus the late bilinguals?
I think my hypothesis, I like to hear also David and I, have talked about this. My hypothesis also based on what Kai has done with us, Kai Suchaichana, who's been one of our colleagues here, and what Karim was talking at the beginning, I think that language is more concentrated. So they're going to tend to look more like the monolinguals, because I think that in development, I think that the neurons are activated early on and they tend to concentrate. Of course, that is a hypothesis that we're going to try to test next, because we do have a population of patients that acquire language much earlier.
Yeah.
Yeah. And I think that relates to the functional MRI question that Jason asked. I think that my thought is that these functional MRIs are relevant. They're very important, but they don't substitute exactly what Dr. Sheehan said as far as doing intraoperatively mapping yourself. But the reality is that the mapping that we're doing myself, even before I start working with David, was really very early in regards to the complexity. We are now doing a lot more complex testing of language function, and David is doing also, he developed some software that is proprietary where he's doing it much faster and is live. And that's when we came with the idea of putting the grid to make sure that when I hear that the patient is having a deficit, I am already know that neurologists tell me no after discharges. So I know that I'm doing something to that brain based on what David is telling me. Now there's a way craniotomies, our goal is to do the entire resection, no matter how big this tumor is, in 45 minutes to an hour and move very, very fast. These patients are wide awake. I'm not talking, I'm talking about just barely local anesthetic that we block these patients even in pre-op. So that's allowing us to learn more. But I think this functional MRI is real. The connectome is real. We just don't understand the Randy, to be honest with you. So
kind of a branching off that, as glioma surgeons, brain tumor surgeons, we kind of subscribe to this idea that extended resection matters, right? It's better for everything, prolonging survival, progression-free survival, overall survival, symptom, quality of life, all these things. Is it worth sacrificing for the second language, or do you think the two language pathways are connected ultimately and you have to preserve both?
So, Dr. Q, can I jump in?
No, you go ahead.
Sorry. To answer the first question, I think our approach is trying to get to know what's important to the patient, obviously. There are some patients who rely very heavily on their bilingualism and their functioning in their everyday life. And in those cases, we might be more hesitant to compromise a second language. And then there's also patients where it might be acceptable. So it's trying to have a candid conversation with the patient of what the surgical risks are and what's acceptable. The second part of your question was,
that's basically it. What the assumption is, it's just basically like, where do you draw the line and say we're willing to sacrifice some of your language or not? But then the second part was saying, actually, do you think you think that both pathways are connected,
Yeah.
even though they're separate to some degree?
So we've had a couple surgical cases where we found complete disassociations in the OR with stimulation mapping and the two languages. I remember one in my mind where it was bilingual, Spanish being the first primary language, English being a secondary language, and I think acquired later. And we had a selective disruption of the primary language and not the secondary language, which was fascinating finding. But
Absolutely.
yeah.
I think,
What
Randy, my view is the following. We have done, there are two papers in the literature. One that we did, Kai and I, with Man McGirt a number of years ago out of Johns Hopkins around 2010, where we show that if we got too aggressive in the resection and we give the patient a motor deficit, specifically motor, that benefit negates their overall survival and the progression-free survival. And then Miriam Rahman out of UF in Gainesville came in and spent, a year when I was at Hopkins with me, and then came back to UF. And then we put some data together from UF where we repeated a similar study that also negated the issue of motor function. So the more you resect specifically for motor function. For speech, we have not done that study yet. And I think that's something that we will have to look at it. And I invite all your participants to think about that. Will giving a patient some sort of a speech deficit negate the potential benefit of the stentor resection? I don't think that we have a clear answer for that yet. Hopefully with the work that you and Nitesh are doing and Jason with radiation, all the stuff, we can one day find a better answer. I think that this is where we can unite forces between the different centers.
It's a complicated set of questions, and I think you're right. We don't have that answer about extent of resection when it comes to primary language or secondary language areas, but we can certainly use that data, and what you've shared with us today, I think, provides a lot of insight to our viewers. So should we hit one question from the Zoom chat?
Yeah, I think Dr. Q already answered it in the chat for the most part. I don't know if we have anything coming in from Instagram, but Flora, if you could want to let us know. Listen, guys, thank you so much. What's that?
Sorry, there's just one question.
What do we got?
It says, does the procedure of fMRI mapping change with the type of language, or does that have any type of effect on neurophysiology?
David.
Sure. I mean, the main difference is obviously we're administering stimuli in different languages. We're still interested in evaluating the underlying process. Again, for example, whether it's phonology or orthography or semantics, but we use appropriate stimuli to map the different languages. But
yeah. Listen, I mean, fantastic work. Obviously, very, very thought-provoking, like we said. I do wonder if, Hugh Defoe talks about restructuring of language with resection of low-grade gliomas. Obviously, this series was a little bit more on the higher grade glioma side of things, which I'm not sure you would see that. But have you guys thought about looking at the data yet to see what happens at recurrence or what happens, to the fMRI and the language mapping when you go back?
You're talking specifically about plasticity of the brain, which we believe
exactly.
Yes, I think that with time, we're trying to put the data, Karim is looking at data that we accumulated between Hopkins, one surgeon, two institutions over a course of time to see if we can shed some more light into that. But I do believe that plasticity exists. We're looking at the functional MRIs that we obtained even at Hopkins compared to the functional MRIs that we obtained in some of the patients that are now beginning to operate over time. I think that there's something there, Randy, and I think that also in the future, hopefully we'll learn how to stimulate the brain. There's a paper that came out of Spain, that the group from Madrid put together where they stimulate the brain, and they notice that even in short periods of stimulation, they can switch the function, motor function specifically on patients. And I think those are very thought-provocative things that we as neurosurgeons, hopefully in the future, will have more to say and more influence. So that way, imagine one day we open the brain, we know the tumor, we cannot take it out, the brain and tumor is invaded by the speech area or the motor area, but we put a stimulator, we let him go home for a few months, and then that function shifts, and then we come in and do a greater stentor resection. I think these are the things that I invite people like Nitesh, like you, to think about it in the future.
So, we're running out of time. What do you think? Should people who learn languages before 6 years old, should they all get Rosetta Stone? Should we be trilingual?
Yes.
Is that protective?
I do agree that we should learn several languages. I think that is a great thing. I have no doubt that if we extrapolate from the data in stroke, I think that our brains are going to be better equipped. It's just like an arm works better if both the biceps and the triceps are working. You know what I mean? So.
All right, fantastic. Thanks so much, everyone. Jason, any final words?
No, thanks. Fabulous work, and look forward to future studies, either in JNO or other journals. Keep us posted with that research. Thank you.
Thank you all of you for your support and allowing us to use your journal as a vehicle.
See you guys next week.
Take
Take
care.
care.
Take care, guys.
Bye.
Thanks.
Bye-bye.
Bye.